Dr. David Ripley is the Chief Medical Officer of HealthBridge Complex Care and Rehabilitation. He is board certified in physical medicine and rehabilitation and also in brain injury medicine. He holds an appointment at Northwestern University's Feinberg School of Medicine, and he's widely published and internationally recognized as an expert in neurorehabilitation. Dr. Ripley is also the author of the chapter in the Life Care Planning and Case Management Handbook for Life Care Planning for Traumatic Brain Injury. So please welcome Dr. Ripley.
Good morning, everybody. Everybody awake? You don't mind if I walk around a bit, do you? I don't like being stuck behind the podium. So, thank you, Christy, for the great introduction. I'd like to thank you and the other members of the committee for inviting me. I know this has been a work in progress for a couple of years, and it finally worked out. This time of year is always a really hard time because there's a lot of conferences, and so always has turned out in the past to be a conflict that prevented me from coming. But really excited to be here, see some new friends and old friends, and look forward to meeting a lot of you. What I'm going to talk about today is kind of the basis of how we approach brain injury rehabilitation from a physical medicine rehab standpoint, and provide, the goal today is really to try to give you guys a fellowship in brain injury rehab in a little over an hour. So see how well I can do with that. Let's see, we got... Okay, slide's not forwarding. There we go. I always like to start with this slide. The human brain starts working the moment you're born and never stops until you stand up to speak in public. So I'm hoping that my brain continues to work. If I stumble a little bit, bear with me, because something probably just kind of got me stopped there. Okay. This clicker's not working too hot. There we go. Okay, how many people have heard of this guy, Phineas Gage? How about raise your hands, who has? Who hasn't? It's about half and half. Okay, so I want you guys to pair up in small groups, and the people who know about Phineas Gage tell the people who don't. No, I'll tell the story really quick. So the reason this is important from a historical perspective is that this was the first really well-documented case report of someone who had a traumatic brain injury in the United States. Meticulously documented by a Dr. Marlowe, who was out of Boston. And so it was really the first real case report. And there's some real key things that kind of are nice takeaways from this case that, it ends up being kind of a nice historical perspective of brain injury and how some of the different aspects of it. So Phineas Gage was actually a railroad worker. He was a supervisor of a crew whose job was to go through, when they're cutting through the mountain, blasting the rocks away so that the railroad the track could be laid. And he was actually, as people would say, a very upstanding, well-respected, honorable member of the community, very, very never cursed, church-going, righteous dude, right? This is a guy who really was upstanding and everybody respected him. And he was actually in charge of this crew. And the way that it worked was kind of like an assembly line where they had several people that would go through and had different tasks while they were trying to blast away all the rocks. So one person, or actually a couple people, would come by and drill a hole in the rock, and then another person would come by and put, the black powder dynamite charge into the rock, and then another person would come by with essentially a packing, a wadding that would protect the charge. And then Phineas, who was kind of following up with a crew, had what was called a tamping iron, and you can see the actual iron here at the bottom. And what his job was to pack that down so that the charge was really deeply set into that hole. So when the explosion went off, it would blow away as much of the rock as possible, trying to move quickly, right? So what happened is they were kind of going through their process and working on this one hole where the person who was supposed to put the packing in didn't put the packing in. So there was exposed black powder and, of course, iron on granite. What happened? Spark went off and set off the charge. And so big explosion occurred. Nobody really knew what would happen. They saw Phineas lying on the ground, and the tamping iron was 30 feet behind him on the ground also. And they figured out that when the explosion had gone off, you can actually see the pathway here. They have his skull on display at a museum in Boston, actually, so you can see this. But they figured out that the path of the tamping iron went right through his left orbit, through his left orbital frontal cortex, which is really important, and exited the top of his skull and landed behind. Now, back in the day, it was really unusual for anybody to sustain an injury like this and actually survive, right? So this is one of the reasons why this case was so interesting at the time, that here's a guy who had a very severe brain injury, had a long recovery process, almost died several times, but ultimately survived. And the key point is that what people said about him after his injury and after he went through his recovery was that he was no longer the same person. They say he was no longer Gage. He became very foul-mouthed, couldn't hold a job, couldn't hold responsibility. He actually ended up, as I understand, down in South America, somewhere the day equivalent of a taxi cab driver. Just couldn't hold a job and ultimately ended up back up with his family in Boston, where he ultimately passed away. But the case was really well documented. So a couple cases in point. One is, it was kind of an initial introduction, or if you will, or evidence that brain injury, if you hurt the brain in different parts, you can have a change in personality, right? We know that very well now, but it was kind of a new thing at the time because people didn't typically survive. And the other thing was how lack of social support systems really affects the recovery of the individual. So he didn't have the same kind of rehabilitation support and all of that. And so his life was chaos after this happened. And so those are the two kind of take-home messages from this historical complex. One of the other things that I would say that I find really interesting is the path of the tamping iron as it went through his head. I mentioned it went through the left prefrontal cortex, right? If he had had the same injury on the other side, he would have a completely set of different symptoms and presentation. He would likely have been abulic. He likely would have had flat affect. He likely would have trouble with initiating activity. So it really is important where the brain is actually hurt. And I'm going to get into that a little bit more a bit later. There's some other things that have happened from a historical context to improve our understanding of traumatic brain injury. World War I, a lot of soldiers started recovering. At that time, battlefield medical techniques, though still rudimentary, were advancing. And people know who Luria and Goldstein were? They're kind of the modern, the grandfather of modern day neuropsychology. And they started studying some of these injured soldiers who came back from World War I and started putting together, hey, that people who have injury in certain of the areas of the brain or certain areas of the head, as they said at that time, will have certain patterns of neurological impairment. And so they started looking at that. And that was kind of the first foray into this idea that different areas of the brain may have different functional neurological components. In World War II, as antibiotics and things like that started becoming used, battlefield, recovery techniques were actually improving. Again, more people were surviving during World War II. And this was a really key point for our field because World War II was kind of the advent of rehab medicine as a field of medicine. There were some great grandfathers of the field that actually came out of primarily the VA system after World War II and realized, hey, civilians could benefit from this type of rehabilitation as well. So that kind of led to the development of physical medicine rehab as a specialty. Other things in the Vietnam War, the big thing in Vietnam was the development of the Mobile Army surgical hospitals units. They got really, really advanced. And there actually started to be a real big cohort of patients who survived gunshot wounds to the head, never survived before. And I don't know if anybody's interested in the research standpoint. There's a gentleman named Jordan Grafman who has a database of injured Vietnam era veterans who's been following for the last 40 years. We're all shot in the head, and he's done some work on how those different patterns of injury affected these individuals. So really fascinating stuff there. How many people know what NIDLR is? It used to be called NIDR. So NIDR stood for National Institute of Disability and Rehabilitation Research, and they just changed it to National Institute of Disability, Independent Living, and Rehabilitation Research. This is in the Department of Health, but this is the supporting organization for the traumatic brain injury model systems. Most people have heard of model systems. Okay, there are 3 different model systems, one for brain injury, one for burns, and one for spinal cord injury. And a lot of the research and understanding of brain injury that we have now actually comes out of the model system. So I'll talk a little bit about that at the end. More recently, the Middle East conflicts, people are pretty aware that the signature injury of these conflicts has been brain injury. It's really increased awareness. There's some misconceptions about the types of injuries that these soldiers is still, of course, not good that anyone's hurt, but there's a lot of misperception about the types of injury that they've had. Other things that have increased awareness is a lot of the work in NFL and NHL, and you guys all know probably recently there was another big case a couple weeks ago of a high-profile quarterback who had a concussion during a sport, probably a little more than a concussion if you look at the video, and so they're under a lot of scrutiny for that. But the flip side is the good news is that there's been more research dollars being poured into brain injury research because of all this, and this has actually helped the field and progress our knowledge. And one of the things that's happened is this study called the TRACK TBI. Has anybody heard of TRACK TBI? Dr. Moberg has. This is out of the University of California. I think it's Berkeley, or it might be Stanford, but Jeff Manley is a neurosurgeon who's in charge of this project. And this kind of goes along with the model systems. One of the criticisms of the TBI model systems has been it's really focused on just rehab and patients that go in rehab. TRACK TBI is really more acute care medicine, neurosurgery, emergency medicine. There are a lot of those people involved in it. So it's really designed to capture a broader population of subjects so that we can have a better understanding again of brain injury. So a lot of really neat work is coming out of that. Concussion, the movie, everybody saw the movie? So again, a lot of things, raising awareness of brain injury. So a lot of things have happened to get us up to this point of where we are and from a historical perspective.
Oh yeah, you're right.
I don't know if the battery's dead in the clicker is. There we go. Maybe I'll just ask you to, can you advance the slides for me?
Sure.
Okay. So a little epidemiology. I'll say these slides are a little bit dated now, but the numbers are relatively same. In the United States every year, we have 52,000 people die. It's actually more recent evidence is a little higher, 56,000 I saw was the more recent data, but about the same, 50 some odd thousand deaths in the United States for brain injury. Incidentally, it's the largest cause of death due to trauma in the United States. Makes sense. You hit your head hard enough, it's going to kill you in a lot of cases. 275,000 hospitalizations, that number's been pretty consistent. One is closer to 1.5 million emergency department visits. We say that there's between 2 and 5 million brain injuries per year in the United States. We don't know how many. And why is that? A lot of people don't go seek medical treatment, right? Anybody had a concussion? I know I have, yeah. So yeah, good, maybe quarter of the group in here. How many of them have you went to the doc? I didn't. Explains everything, right? So yeah, a lot of people don't seek medical treatment after a concussion and don't realize, you know, it used to be thought, oh yeah, you got your bell rung, whatever, no big deal. And that was kind of the attitude about this in sports. Hey, you rung your bell, get back in there and keep fighting, win, right? Just a little personal note, one of the reasons why I got interested in brain injury was because my uncle was a star high school running back. And as a sophomore, he was already being recruited for college football and was in a game, got concussed in the game. Coach put him back in, say, we still need to win the game. He got back in, got concussed again. Get back in the game, third time he didn't wake up. And sustained a severe brain injury. He's had trouble with aphasia and seizures and things his whole life because of that. So our understanding of concussion and the severity has really improved greatly in the last few decades. So numbers, we say conservatively 1.5 million brain injuries per year in the United States. This is, if If you look over here, compared 1.5 million brain injuries compared to breast cancer, HIV, AIDS, spinal cord injury, and multiple sclerosis. So there are more brain injuries per year in the United States. And again, this is a very conservative estimate of numbers than all of those other disorders combined. So if you took any other medical condition, this would still be considered an epidemic, right? Lots of people are having them. It's a thing that we need to have greater awareness of. And it used to be, this is changing because of all the historical things that I just talked about, but it used to be that the funding for research for these different disorders was almost inversely proportionate. Had a lot of research in MS, a lot of research in MS, a lot of research in SCI. Not as much in brain injury, but that's changing. So next slide. So just again, kind of a conversation discussion about brain injury numbers in the military. You can see this slide going back to 2005, and all of a sudden you saw this huge increase in the numbers of brain injury in the military. And there are a couple things about that. Of course, we were heavily engaged in the Iraq, Afghanistan conflicts at the time. So there were more injuries happening. However, the military, the Department of Defense, also tried to be more inclusive of making sure they were capturing all the brain injuries. So they broadened the criteria for what consisted of brain injury in the reporting. So it really came down to anybody who had a self-report of any of the symptoms was recorded as having a brain injury. So again, the numbers are a little misleading. It wasn't like sometimes it was reported in the news that there were all of these patients with these devastating brain injuries. It just wasn't really like that. So next slide. You can see that the vast majority of these, the yellow line, actually represents mild brain injuries. So the big numbers are really coming from patients who were exposed or near to a blast, may have had a mild injury, but it wasn't like these people have really, really severe brain injuries. In fact, most of the more moderate to severe brain injuries were relatively stable. Still, not to minimize the impact on these soldiers. Okay, brain injury by cause and age. We say that it has a bimodal or a trimodal distribution. Tends to happen in the very young and tends to happen in the very old. And there's another smaller peak right in the teen to early 20 age years right here. Everybody knows what that's from, right? Novice drivers. So motor vehicle crashes during that time is the number one cause for young adults, late teens. Falls, however, are the biggest cause overall. You can see that they tend to hurt, if you look at the black line, happen in the very young and the very old. And one of the reasons why we say brain injury may be increasing as the population ages is you have more of these people entering older adulthood and falling because they're losing balance and so forth. Now, the other thing that I find really interesting is that some of the perception is that a lot of these people are, grandma with her walker and, tripping on the sidewalk coming home from church, when actually the research suggests that older people are staying engaged in much more active, sports related activities than they used to. This is great. So you have more people who are in their 70s who are injured snow skiing and, rollerblading and so forth. So I think that this is great. But one thing to keep in mind, and we'll talk about this a little bit later when we're talking about prognosis, is an older brain doesn't respond as well to a younger brain when it gets hurt. That one of the biggest factors that affects your prognosis after an injury is your age. So it's just as you age, those factors that help you recover don't work as well. And also there's some fragility with the brain. Some of the blood vessels and things are more likely to get easily disrupted and so forth. So a lot of patients with the same type of brain injury or same force, an older person is going to end up with a more severe and a worse outcome. Okay, so etiology, I mentioned this already. Biggest cause of brain injury in the United States is falls. This is actually fascinating to me because when I was a resident, motor vehicle crashes were the number one cause, and that's changed just during my career. And a lot of it probably has to do with the aging of the population and so forth. Some of it may have to do with improved safety, right? We've done a lot in the last 4 decades of improving the safety of cars and restraint devices and so forth. So a lot of people survive crashes that historically they wouldn't have. There was a really interesting slide, I don't know if anybody saw this, that was comparing cars from different eras and what would have happened to the driver with a similar accident. And one of them was a 1990s Ford Taurus or something compared to, a Ford Galaxy from 1960. And it showed that from the same impact, the driver who was in the newer car with airbags and restraint, good seat belts and everything in the crumple zones would have walked away probably with an ankle injury, not hurt much at all. And the person who was in the older car was dead on impact. And so a lot of advances in automobile safety technology have really helped improve the survivability. The flip side of that is that people are surviving more serious crashes, right? So you are having people that maybe wouldn't have survived before, who are now surviving and need rehabilitation for their injury. Okay, so how do we classify brain injury? We're going to shift gears a little bit and talk about, kind of get into how we prognosticate, how do we assess, and this is kind of the beginning of your fellowship in brain injury medicine in an hour. So we have a lot of different ways in how we classify injury. The most common way worldwide is using a system called the Glasgow Coma Scale. Everybody familiar with the GCS, Glasgow Coma Scale? Okay, we'll talk about these different scales in a minute. Duration of loss of unconsciousness is one that's also used primarily in sports medicine. Okay, duration of post-traumatic amnesia. Post-traumatic amnesia is the duration of time it takes for an individual to regain ongoing recollection of events after an injury. All right, so during that time, the person really is not able to form new memories. It's actually exactly backwards from the way it's portrayed in the movies, right? You don't forget who you are. You don't forget what you did for a living. You don't forget your family. You don't forget how to speak English. What you have trouble with is remembering new things or, forming new memories. So you remember all that old stuff, but it's the new stuff that's weird. So when I go in to see a patient who's had a brain injury, they don't remember me. They remember their wife or, boyfriend. So that duration of time that it takes to regain that ongoing memory is a good measure of severity of injury. Rancho Los Amigos stages, most of the life care planners are probably familiar with this, right? Something that's readily used to classify brain injury now. Etiology of injury, what happened? How did the person get hurt? So that's a way of classifying injury. It kind of goes more towards what are the forces involved in the injury. And frankly, it's not really used much clinically. It's just kind of an interesting sidebar. I like to note, hey, this person had a fall from a 20-foot ladder, or they're involved in a motor vehicle crash, side impact, that kind of thing. Kind of tells you a little bit about the forces that might have been involved, and that gives you some information about how that might have affected the brain, right? There's some knee-jerk things I like to talk about when I'm talking with the residents, that if you have somebody who has a motorcycle crash and they have a brain injury from a motorcycle crash, you should immediately start considering whether they had a brachial plexus injury. Because what happens when you hit your head, you distract it from your shoulder. And a lot of times brachial plexus is hurt too. And a lot of times in the acute care hospital, person has a weak arm, they're going to attribute that to the brain injury and not think, hey, there might be a peripheral nerve injury as well. So you kind of have to think about how etiology occurred. And last and most important is anatomy of injury. This is where what was beat into my head by my mentor is how you assess injury. I'm going to kind of present a slide with him a little later on. Okay, GCS. Does anyone know the story of the GCS, Glasgow Coma Scale? Okay, it's kind of a fascinating story. There was a group of neurosurgeons who actually their biggest interest was in disorders of consciousness after brain injury. How do people recover? Really fascinating. Plum and Posner. One was American, but the other guy, and I forget which is which, but one of them was at the University of Glasgow. And what they were doing was they were taking care of all these drunk Scotsmen who come in after Saturday night after getting beat up, and they ended up in the ICU, and they wanted a quick bedside way to track, hey, is this person getting better after this, or are they getting worse? And so they devised Glasgow Coma Scale score. So it was really designed as a bedside assessment to determine if somebody was recovering consciousness or are they deteriorating. And that kind of gave them evidence before we had CT and MRI and all these fancy radiology techniques to determine, hey, we need to intervene for this person? We need to do anything. And so that's how it was devised. So it was not really originally designed to classify brain injury. It was really designed just as a crude, quick bedside assessment. Lo and behold, however, there was some research that was done that showed that it actually had a pretty good predictive value for long-term outcome. They started looking at how people recovered based on their GCS at 1 year after injury, and they found, hey, there's actually a pretty good relationship here. If you have a low GCS when you first come in the hospital, you're going to have a worse outcome. And there's been lots of research on this consistent. So really, really actually kind of an interesting thing that now is used not for its really intended purpose, which was to track recovery, but it's used to classify injury. And you'll hear people all the time say mild, moderate, severe injury. This is really what it goes back to, right? So the Glasgow Coma Scale itself has 15 points, 3 different subscales. The 3 subscales are eye-opening, motor response, and verbal response. And you rate the patient's response, best response to stimuli on each of those scales, and you add them up. So a couple things to note. The scale goes from 3 to 15. 3 is as low as it gets. There's no 0, 1, 2 on the Glasgow Coma Scale. So if you see that written in a chart somewhere, you know automatically that person didn't know what they were talking about. They didn't understand, all right? I guess some medical professionals get confused when a patient's intubated and don't score that. What you need to do is grant that person, if they're not able to respond verbally because they're intubated, you give them a 1 T. T indicates that the patient was intubated, right? So really the lowest you get is a 3 T in that situation, right? It's also been found that the motor subscale, incidentally, has the best of the 3 subscales, has the best predictive value for outcomes. So there's been some work that shows motor subscale, really motor is the most correlated with outcomes. So you want to pay close attention to that subscale, all right? What are the limitations of the GCS? One of the things that I get kind of a little annoyed by, I guess, is that you hear somebody say in a record, this person, or that you're talking to a professional and say, well, they act like a severe brain injury. And I will say, well, what does that mean? You have 100 people with 100 brain injuries, all of them a Glasgow Coma Scale 3, and they're all going to recover differently. And why is that? Because the areas of the brain were affected were different. And the way that that person recovers is going to be different. So this doesn't by itself tell you much about how the individual patient is going to do. It does give you information about statistically long-term outcome. Is this person likely going to need assistance? Are they likely to be impaired at 1 year? But it doesn't really tell you how and why and what you're going to need to do. So that's a limitation of the GCS. The other thing is, when do you do the GCS? All right, so you have a patient who's hurt in the field, the emergency medical technicians come by, they do a GCS, and that person's GCS is a 9. They get to the ED, they're sedated and intubated, their GCS is 3T. The next morning, when the nurse surgeons come around on rounds, they've been extubated and they're up in the bed talking, they're a 13. So which scale do you use? So model systems database suggests, in their criteria, the best post-resuscitation GCS in the first 24 hours. So that person probably had a milder injury. I'd say probably hedge your bets a little bit, but just in that case, you want to take the best post-resuscitation score, right? So when you do it is also important. When is the GCS actually recorded? You're lucky a lot of times if you get 1. You're really lucky if you get 2. Most of the time it's assessed in the field and in the ED. What's the other thing that limits this? I just kind of mentioned that scenario. In the field, they were a 9, and in the ED, they were a 3T. What happened? Yeah, the emergency medical technicians, they sedated and intubated him, right? So his GCS was 3T, not because of the brain injury, but because they paralyzed the guy and stuck a tube down his throat. So he couldn't respond, right? So that's not really that helpful when it comes to classifying how severe somebody's brain injury was, right? So there's some limitations to this, and this is actually becoming more and more common. I'm not in any way, I think it's great what's happening now as far as the interventions in the field for improving outcome and saving brain. And we've shown that a lot of the things that the advances they've made in emergency medical technology to get this, the patient calm, sedated, intubated, protects their brain. It's good stuff, but it still limits our ability to use the GCS as a rating scale for how severe the injury was, right? Okay. Ceiling effect. This is another thing that's been a big thing in model systems. And also if you work at all in mild brain injury, somebody comes in with a GCS of 15, 14, that's still a mild injury, but it really doesn't necessarily capture the severity of the impact for the milder injury. And you can see that once a patient's awake, alert, oriented, and following commands, GCS doesn't really become that useful as a rating scale anymore, okay? So it's good for early assessment, not really good for longer term. So the other thing, just to mention, this was a really kind of an interesting sidebar. There was a research study that was looking at the association between alcohol on board at the time of injury and outcome after brain injury, all right? Now, this is actually based on some really solid rat research that suggests that alcohol may have a neuroprotective benefit, that they were doing experiments where rodents were exposed to alcohol, they did an experimental head injury, and the rodents that had alcohol on board actually had better outcomes. They didn't have as bad an injury with the same experimental head injury. And so they thought, hey, we'll look at this in human beings. So they decided to do a study where they took patients who came in the emergency department, they rated them by their GCS score, and they also looked at how much alcohol they had on board, and then they looked at the one-year outcomes. And what did they find? They found that alcohol was associated with a better outcome, all right? So what's the flaw in this here? The alcohol lowered their GCS score, right? They were drunk, so they couldn't respond as well on the score. So you can see that there are a lot of limitations with the GCS. It's not the end all be all. It's still a really good scale, really good relationship to how we assess long-term outcomes, but you can see there's some problems with it, right? I also really have issue with just globally classifying everybody as mild, moderate, and severe. The reason is it just doesn't tell you that much about the injury. So we have the Asia score for spinal cord injury, right? So we have this very sophisticated rating scale, level, completeness of injury. We don't have anything like this for brain injury, which is really fascinating. So you have a much more complex injury that then is being rated with this very crude scale into these very broad categories. And we're trying to do research on how different interventions work on these patients. We really don't have a great way of assessing like the Asia scale. So just something we need to have. Okay. Duration of post-traumatic amnesia. So this was proposed back as early as 1932 by Russell as a good measure of severity of injury. We track it using several different methods. One is, probably the most common one is called the GOAT, the Galveston Orientation Amnesia Test. This is a 100-point scale. And if patients score above a score of 75 for 2 consecutive days, they're considered out of post-traumatic amnesia. Now, the measures on the test are orientation questions like, do you know what day it is? Do you know what the name of the hospital is? Do you know what floor it is? Can you tell me what happened to you? Those sorts of things. And so you rate the patient every day. And once they get 2 consecutive scores on two different days of a 75 or greater, then they're considered to be out of post-traumatic amnesia. There's a newer scale now that's kind of more commonly used in our facilities. We use this called the OLOG, which is actually really a simpler form of the GOAT. It just has fewer items, and it was found to have good correlation with the GOAT. So more people are using that now. It's just simpler. Has the same thing. Same deal. The OLOG goes to a scale of 30 points. And so if you score over 25 2 consecutive days, then that considers that you're considered to be out of post-traumatic amnesia. So the duration of time that it takes for somebody to regain ongoing recollection events, I would consider, along with many of my colleagues, this would be the single best indicator for how severe somebody's brain injury was, because that duration of time is really not affected by much that we do, right? There's been all of this research looking at different techniques to try to improve orientation, memory books, calendars in the room, all this kind of stuff. And most of them really found not to have much effect at all. It's really a function of the neurology of the injury. And this recovers, it takes the time it takes to recover. And that's why it's a really good kind of indicator of how severe somebody's brain injury is. What's the problem with this scale? Most hospitals don't collect it. So a lot of rehab hospitals do, but if you go in the acute care hospital, a lot of them don't know what the code is. They just don't do it. You're lucky if you have a speech therapist who's been consulted early on and starts doing these things, but usually you don't have that level of detail. So that's the problem. So not necessarily as useful. Loss of consciousness. Okay, this is a picture of Tua the other day. So most of the research in more severe brain injury has found that duration of loss of consciousness is not really a good correlate with outcomes at all. Now, it may have some benefit. The hedge or caveat to this is it may have some benefit for the milder injuries, because looking at people who had no loss of consciousness versus maybe a few hours of loss of consciousness, that actually may have some benefit when you're rating how severe a concussion is. But for the more severe injuries, it really doesn't seem to have much of an impact. So not really something that, I tend to see the more severe injuries. I see, you used to see a substantial portion of concussion, but not as much anymore. But for the more severe injury, loss of consciousness is not something that's really considered to be that helpful, poor correlation with outcomes. Now, the irony is that when they came out with the new codes for diagnosis, the ICD-10 codes, loss of consciousness was right smack in the middle of that. So there are other things that I think would be more helpful, but that's how the people, I guess the international, World Health Organization that comes up with that decided to classify it. Okay, Rancho Los Amigos stages. Everybody heard of this? Okay, I love the original Rancho Los Amigos stages. So a little history here. This was created by the group at Rancho Los Amigos, which is a rehab center in Southern California. Very well, great reputation. Actually, back in the 70s, was probably the premier brain injury rehab center in the country. There was a Dr. Hagen, who's a psychologist with a couple of grad students, put the scale together. And if you look at the original scale, it actually went to 1 through 8. So if you kind of cut it off here and just look at this, that is the original scale, 1 through 8, stopping at purposeful appropriate. It really elegantly correlates with recovery of function of the brain from deep brain to cortex. So it's really fascinating. If you look at the first 3 here, no response, generalized response, localized response, those are essentially correlating the Glasgow-Coma scale motor scale. Okay, you're recovering deep brain injury, brainstem function, arousal, all of that. You go a little further, confused, agitated. You've got limbic system function coming back online, and the patient still has impaired cognitive processing speed. Level 5, confused, inappropriate, frontal lobe functions not working. So as you move up the scale, what you're seeing is a correlation with recovery of brain from deep brain to cortex. And the level 8, purposeful appropriate, that's really kind of tells you that everything is kind of integrated. Now, that person may not be normal. They may still have neurological impairments, and they likely do with a severe injury, but everything is kind of working in sync. Everything in the brain is kind of working together with respect to those areas of injury that are focally affected. So what happened? Why did they revise this? Well, this was really designed to be used as a communication tool. It kind of gave a snapshot of where that patient is in their recovery. And also as an educational tool to talk to families about what to expect as a patient's recovering, right? The big one that everybody likes to talk about is Rancho 4, right? This is our favorite patients, confused and agitated. These are the guys that are, restless, they're swinging, very difficult to work with, and many rehab places don't want to take them because they're hard. So it's helpful to actually demonstrate the Rancho stages to a family early on and say, hey, look, your family member's not waking up yet, but we think they're going to wake up. And when they do, be prepared because they're going to get agitated. This is a normal stage of recovery. And so it's reassuring to say, hey, this is actually a sign this person's getting better. Because a lot of times if the family hasn't been indoctrinated with that, they say, fix it. He looks uncomfortable, because they do look very uncomfortable. Right? So why did they change the scale? Well, this goes back to insurance, right? Insurance started using the Rancho stages as a outcome measure. And again, kind of like post-traumatic amnesia, this is really a function of neurology and less a function of anything that we do to the patient, all right? And so what happened was when you get to level 8, most of the patients, particularly when they're going to the post-acute residential programs, were already level 7, level 8. So a lot of times they were getting denied coverage by insurance because they said they're not making any progress, right? They've already maxed out, so you need to send them home. So, well, wait a second, they're still having issues here, and here. So the powers that be, Dr. Hagen, and group company decided to modify it, and they added all this language on the side, okay, and then added 2 more categories. And this is really to capture those patients that are in those post-acute settings that are improving in their need or lack of need for assistance for different activities, right? But have essentially kind of made that neurological improvement to that purposeful, appropriate stage. So what do I have a problem with this? What is this? Does anybody know what this scale is that uses this language? Total assistance, minimal assistance, moderate assistance, FIM scale, functional independence measure, right? Who said that? Awesome. So what is a FIM scale rate? Function of different tasks, right? So, you know, with the FIM scale is designed to measure how much assistance a person needs with a particular activity, right? Like how much assistance does a person need to put on their shirt? How much assistance does a person need to put on their pants? How much assistance does a person need to go to the bathroom? And you rate each of those activities on the FIM scale 1 to 7 based on how much assistance they need. Minimal assist, moderate assist, maximal assist, totally dependent. And you get a score. And you can add all those scores up and you get an overall FIM score of how functional the patient is, right? So when you say total assistance on the Rancho stages or maximal assistance, what do you mean? Which activity is important? Because you have patients, everybody who's done the FIM knows, you have somebody who may be independent with eating and totally dependent with toileting, right? What do these 2 things have to do with each other? And do you average them? I mean, I don't know. So I think that what we should have done is come up with a different scale, frankly, you know. But this is what the industry uses, so everybody's aware of it now. One other thing about that, let me go back 1 second. The Rancho Los Amigos stages, I still think its best use is as a communication tool, right? So if you have professionals talking to each other across the country, I can get on the phone and say, hey, Dr. Moberg, I've got this patient who has a brain injury from a motor vehicle crash. They're a Rancho 4. Automatically, Dr. Moberg knows exactly what that patient looks like, right? It's confused and agitated patient. Yeah, we can take care of that patient in our program. So it's best use of that communication tool. The other thing to keep in mind is it's most useful with certain types of injury, all right? And I'm gonna get into this a little bit when we're talking about anatomy, but patients with focal injury don't tend to follow the Rancho stages, 1, 2, 3, 4, 5, 6, 7, 8. Patients with diffuse injury and deeper brain injury tend to. So like I said, the Rancho stages really track recovery of function from deep brain to cortex. So if you see, this is designed to track those patients with more diffuse injury, more deeper brain injury, and how they recover. So the other thing to keep in mind is that patients don't always go through the scale 1, 2, 3, 4, 5, 6, 7, 8. They can skip around. I've had many patients who present with a DOC and they don't ever go through an agitated stage. They just kind of wake up and start doing their thing. So it's not necessarily so that everybody is going to go through each stage. And in fact, more people who have a focal injury tend not to follow the stages. They kind of tend to be one stage for a while and then time passes and then all of a sudden they're the next. So it's better used for tracking patients with diffuse injury. All right, let's talk about anatomy. So this is something that the late great Mark Silo beat into my head over 3 years at Craig Hospital and really became the way that I believe brain injury should be assessed, analyzed, and how we prognosticate. So we base it by the type of injury and the anatomy of the injury. So we have 3 broad categories. The 2 biggest ones are focal and diffuse, okay? And they're kind of what they said. Focal injury, we're going to see some pictures of this in a minute, is a single area of the brain that's been affected. Diffuse injury is diffusely throughout the brain. Most patients with a severe brain injury, in addition, have a degree of hypoxemia associated with their injury. The reason why the EMTs sedate and intubate people in the field is that when you hurt the deep brain structures, you lose your respiratory drive. So a lot of people have lack of oxygen for a period of time. And so they secondarily have a hypoxic injury on top of it. It's important to understand the different areas that are affected by this when you're prognosticating. So I like to include that as a separate category. And there are other people that have solely a hypoxic ischemic injury, and we'll talk about that too. So focal injuries, a lot of different causes. You can have subcategories of penetrating versus non-penetrating, exactly like it sounds. Intracranial hemorrhage, I classify along with this group because people who have collections of blood within the calvarium, tend to behave the same way. So for these patients, in general, the recovery mimics a stroke. And what do I mean by that? Like a stroke, you have a focal area of injured nerve and tissue that corresponds with a focal neurological effect. And for most part, depending on the size, extent of that area and what the function is, those patients are going to have a permanent deficit related to that area of injury, right? It's going to get somewhat better, but it's probably not going to get all the way better, okay? These are the people that tend to have the arm that doesn't work or the language impairment, something focal neurological deficit. These patients take a shorter time to reach their final endpoint. So most people have heard that recovery after a brain injury takes 6 months to a year. How many people have heard that? Yeah? This is kind of old news, old thinking. We know now that depending on the type of injury, it can take several years for somebody to reach their final endpoint. But people with a focal injury tend to reach their endpoint sooner. And that 6 months to a year, yeah, that's kind of the ballpark when most of these people kind of reach their final neurological outcome. Conventional indices of severity of injury are not as useful. I'm talking about the Rancho Los Amigos stages when we're tracking them. So, okay. We break these down into some other things. Focal cortical contusion, you may see me write this in a chart somewhere, FCC. This is a lesion that is circumscribed in a particular area, right? The pattern of injury that is most common for all people, regardless of the site of impact on the skull, is the orbital frontal and anterior temporal part of the brain. And why is this? If you take the top off the skull and look at the inside, in the human skull, it's actually really smooth all the way around. The exception is the floor of the skull. A lot of little rough bumps, grooves, ridges, particularly the temporal ridge. And when the brain is hit, what happens? It slides around in there. The consistency of the brain is kind of like a big piece of jello floating in water in a big bony ball, right? And so when you smack the head on one side, brain's going to move around inside of there. As it rubs over all those rough little areas on the floor of the skull, that tends to bruise it. So there's been some research to suggest that regardless of the site of impact, the most common pattern of contusional injury is orbital frontal, anterior temporal. And that's where you got to get a lot of this. They act like a brain injury because you're going to have a kind of repetitive pattern of neurological deficits associated with that. Disinhibition, dysexecutive function, impulsive behavior, all of that. Okay. Everybody heard the term coup contre coup? Okay, so coup contre coup, blow counter blow. You can actually have a pattern that's directly opposed on the side of the skull, depending on where the skull is hurt. You see this more often in side-to-side impacts, you know, where you'll have a blow on one side of the head, and then you have a concomitant injury on the opposite side, and it has to do with the rapid movement of the brain back and forth inside of the skull. Often you'll have a greater neurological injury, brain injury, on the opposite side from where the blow occurred. It's difficult to explain on the stand sometimes, but this is why. Okay. Penetrating injuries, again, these are usually associated with assault, more common in urban areas. You're going to see focal deficits associated with the missile tract or the track of the penetrating object. These are really interesting to take care of because you a lot of times have relative sparing away from the area of the missile tract. So you have some really interesting recovery patterns. And this is where that Vietnam study really kind of is very interesting, Dr. Grafman's study, because these patterns of injury that the Vietnam veterans who've had, you know, a gunshot wounds to the head, they really don't follow some of the same patterns that you see with the, you know, model systems cohort and so forth. So anyway, that you can see some really interesting recovery that is unexpected because of that. These patients, because you've penetrated the, you know, the coverings of the brain, they have a much higher risk of infection and much higher risk of seizures. So it's really, really common for these patients to have an interruption in their rehabilitation course. Often they'll get an infection. And often these folks, because the infection that's brewing is inside the calvarium, they don't really have the same clinical signs and symptoms that you would expect other people to have with infection. They sometimes don't have fevers and so forth. And it's often not until very late that the patients exhibit any signs at all. So you have to have a high index of suspicion. But a lot of these patients have interruption in their rehab progress because they've got to go back for washout, additional surgery, and so forth. So really complicated cases. Hemorrhage. So the different types of hemorrhage I classify as focal injury because they have the same effect. Often the effect on the brain is that there's compression of vital structures neurological structures. And because of that compression, it causes neurological dysfunction. And you'll have a corresponding neurological deficit that corresponds with where that injury or where the bleeding is occurring. If this isn't treated in time, this can result in herniation, death. So epidural hematomas, I'm going to talk about the difference between these in a second, but epidural hematomas are associated with a high likelihood that the patient's not going to survive. Why is that? Because it's a rapidly expanding lesion, and often the patient doesn't get to the hospital in time to have that evacuated and treated. And so it just rapidly progresses and patient dies. So this is the most recent or most common cause of somebody who has a head injury where they have a period of lucidity. They're fine, they're fine, they're fine. Skiing downhill, hit a tree. I'm fine. Ski down to the bottom and all of a sudden collapse. A period of lucidity followed by deterioration. We classify these by where they're located in relation to the meninges, which are the coverings of the brain. So you have the three big ones, subdural, epidural, and subarachnoid. Okay, let's talk about those for a minute. Just a reminder, there are three different layers of coverings of the brain. You have your most close level, the pia matter, which closely adheres to the surface of the skull. On top of that is the arachnoid layer, which is on the surface of the brain, sorry, but doesn't go down into the sulci, which you can see here. And then the dura, which is a hard, kind of thick connective tissue layer that kind of covers the whole thing. It doesn't kind of go down at all. And so in between the dura and the skull, there's not anything usually there, except just a potential space. So depending on where the bleeding is in relation to the coverings is how we classify it. So this is an epidural hematoma. Epidural hematomas tend to have what we call lentiform shape, okay? They're convex. This is it here. And the reason it has this shape is that this is outside the dura. So the dura adheres to the inner table of the skull at various parts. If it bleeds in here, it's all kind of kept in place by where that dura is stuck to the inside of the skull, right? These usually are arterial bleeds. So they're rapidly expanding, very serious, and can progress if they're not treated quickly. I love taking care of patients who survive their epidural hematoma because they usually have a better prognostic outcome, because underneath this, if they evacuate the hematoma, they actually didn't have as much underlying brain injury. And research has actually shown that there's a stronger correlation with other types of hemorrhage, subdural hemorrhage, with long-term morbidity mortality than epidural. But these patients are less likely to survive if they don't get treated soon, okay? This is a subdural hematoma. Difference is this has a crescent shape. So here's a subdural hematoma. Actually, incidentally, this is a CT scan. You see blood on a CT scan is bright when it's fresh. This is what I would call an acute on chronic subdural. This is older blood up here, and this is probably still fresher blood. So since this is underneath the dura, the blood is more likely to be closer to the surface of the brain. Most of these injuries are venous injuries. So a lot of times, a lot of older people will get subdural hematomas. They have a simple ground level fall, hit their head, and they're fine for a while. And then people start noticing, hey, dad isn't acting right. He fell a few days ago. Take him to the emergency department, you find out they've got this slowly progressive subdural hematoma, right? So for our severe traumatic brain injuries, a lot of patients will have a subdural hematoma because this implies that there's been disruption of the veins that are right on the surface of the brain too. So it's more commonly associated with worse underlying brain injury directly to the brain, okay? So that's why the morbidity mortality is worse with these. This is a gentleman who has an 80-something-year-old brain, and this is a demonstration of subarachnoid hemorrhage. And you can see here how the blood, the bright blood, is kind of tracking down into the grooves on the surface of the brain, the sulci, okay? A lot of times you can't see this on CT scan just because the sulci for a younger person are so tight, all right? So this gentleman has a nice older brain with nice wide sulci. So just to show the blood tracking down in the sulcus. This is actually on the other side of big hemorrhagic contusion, but that's a good example of subarachnoid hemorrhage there. Okay, these patients, you have to be a little concerned about seizures and hydrocephalus, because this implies that blood is underneath that arachnoid layer. It's going to get into the systems of reabsorption of cerebrospinal fluid that leads to hydrocephalus. So you can have it with other forms of brain injury as well, but you kind of have a little higher index of suspicion when you see this. Blood is very irritating to the surface of the brain. So when the brain is irritated, it's more likely to seize. And so that's the association there. Okay. Skull fractures, just in general, if you see somebody who has a skull fracture, this represents they had a more severe blow to the brain. It just takes a lot of force to crack the skull. It's a pretty strong bone. And so if somebody has a skull fracture, you realize, hey, this is a worse injury. This person really got hurt. When you disrupt the skull, also, you have a stronger association with things like the epidural hematoma, because little blood vessels pass through the skull also, and you may have bleeding associated with that. And again, anytime you disrupt the coverings of the brain, you're more likely to have infection. Okay. Other focal injury, I kind of throw this in here as focal because when you're talking about specific focal structures, I kind of like classifying it in this, but many people are now, I think we have a talk later about hormonal dysfunction, pituitary dysfunction. So this is kind of a relatively newer thing, that there's a recognition that there's been an association between hormonal dysfunction and brain injury. And a lot of the symptoms that we see after brain injury, in some cases, may actually be due to hormonal dysfunction. Kind of makes sense. The pituitary gland itself is highly susceptible to injury along with brain injury. It kind of sits in this little area right here called the sella turcica. And this is really the only area in the brain other than cranial nerves where the brain is kind of tethered. So you can see if the brain is sliding around and all, then that little connection called the infundibulum can be torn, cut, so forth. And this is a great view of the floor of the skull. Remember I mentioned the rough, bumpy ridges that lead to contusional injury. You can kind of see how rough that is there. So the other thing that's really important to understand is that cranial nerves, cranial neuropathies are really, really common after brain injury. If you look on the floor of the skull, you see all these little holes here are where the nerves pass through. So a lot of times if you have a head injury, brain's moving around in there, you're going to have stretching, tearing, injury to the cranial nerves as well. Very, very commonly. And this also really affects the patient's rehabilitation progress, right? Because one of the things that's going on when you're recovering from a brain injury is you're trying to regain the assimilation of the sense of your environment, right? What's going on around me? How do we assess that? Through our senses: vision, hearing, smell, temperature. Where are the organs that collect that? Well, your eyes, ears, and all this information is transmitted by the cranial nerves, right? So if you have injury to those, then the information that's coming into the brain is inaccurate, right? Person's not able to see the full or see accurately what's going on around them, not able to hear accurately. And then if you put that on top of the fact that their brain is hurt, the organ that's supposed to make sense of all this, and you're getting bad information, can you see how confusing this is to the patient? Normal things really become very disturbing. So the cranial nerve injury actually really has a big effect on recovery after injury, right? All right, we're going to talk about diffuse injury. Remember, broad categories. We've talked about focal injury. Now we're going to talk about diffuse injury. So DAI, diffuse axonal injury. There's a newer term, TAI, traumatic axonal injury. I like DAI better. Just like it. So this is sometimes microscopic. Sometimes the injury you don't even see on scan. Back when I started, before MRI was widely available, you'd have CT scans of patients that came in, and it was really difficult sometimes to explain to the family that, yeah, this person had a severe brain injury when the CT scan is read as normal. Happened all the time. And the reason was that at that time, the radiographic techniques just weren't sophisticated enough to pick up on some of this injury. It was microscopic. The techniques we have right now are much more sophisticated, so we're able to see it better. Sometimes not. So these are the patients, because you're more likely to affect deeper brain structures, or more likely to have impaired level of consciousness, impaired arousal. So these guys follow the Rancho stages, 1, 2, 3, 4, 5, 6, 7, 8. They recover more slowly. So these are the patients that when you say recovery from brain injury takes 6 months to a year, throw that out the window. These patients will sometimes take 2, 3 years to recover. There's actually been some really interesting cases in the literature. Most people have heard of the Terry Wallace case, the firefighter that was in a coma for 18 years and recovered. Probably wasn't in a coma, but he recovered significant function many years after his injury, okay? And what was happening? He had neuroplasticity, things were rewiring, more integration of brain function. These patients are less likely, in general, not always, but in general, they're less likely to have focal neurological deficits. Depending on where the lesions occur, you're less likely to have the weak arm or the speech and language impairment. And frankly, a lot of these people actually look relatively normal to lay people if you're not doing, detailed assessment of the neurocognitive function. So it may not be as evident that they had an injury. They do tend to have some other things that are really common with this. Most commonly is fatigue, though. Cognitive processing speed and fatigue are really commonly associated with diffuse injury in the long term. And this is often enough to affect their ability to return to work and have meaningful, gainful activity. So big issue. There's a lot of greater awareness of fatigue now. Okay. This is a CT scan. This is often all you see. You see the little punctate hemorrhages, they call them, little bright spots here. These represent little tiny microscopic, these are larger than microscopic, little tiny areas of hemorrhage within the brain tissue, okay? And they're associated with a lesion, a little focal lesion. Now the most common, there are two big theories of how diffuse injury occurs. There's a biomechanical theory and there's also a biochemical theory. If you read a lot of textbooks, a lot of them will talk about the biochemical theories. And that's that when the brain is injured, there's a release of substances into the substrate that surrounds, all the nerve tissue and nerve fluid. And these substances, calpains, actually disrupt the nerve cell membrane and cause some of them to rupture and so forth. And they've actually found that this is a really common pattern for rodents in the lab. Okay. For patients who have the trauma, what is more common actually is what we rotational forces. So this is usually due to torque, right? So if you're riding on your motorcycle at 100 miles an hour and you hit a rock and you're flying off over your handlebars, you're about to hit your head on the tree, what do? You turn your head away from the impact, right? So a lot of times, right when the moment of impact occurs, particularly with high velocity, high momentum type injuries, that rotational force applied to a sudden acceleration, deceleration force causes torsional forces on the brain. And if you think about the anatomy of the brain, what do you have? You have a stalk, like a mushroom, the brain stem. It's covered by the cortex and all the higher areas. So those rotational forces are kind of applied in these rotational fashion all the way down through the brain to the brainstem. And so where the brain tends to be hurt worse are areas where there's an interface between different consistencies of brain tissue. So this is often right at the subcortical white matter, gray matter interface, because the nerve tissue generally is going from being covered with myelin and being protected to being uncovered. So that causes an area of the force to be applied there, and you have the shearing. Deep gray matter in the brain also is selectively affected, and then the brainstem has a lot of gray matter in it. So this is why those areas tend to be selectively affected. And here's one of the later MRI techniques that shows, this is called gradient echo MRI, and you can see the little punctate hemorrhages here, little black spots. And these spots right here are kind of classic. This is the gray-white matter interface. This is deep within the thalamus. So you can see, and I have a slide, I think, later that has a little more evidence of this. Okay. Hypoxic ischemic injury, the thing to understand about this is that lack of oxygen to the blood and blood flow to the brain. Some people use the term anoxic brain injury. Actually, in the literature, you'll see this. These terms are really interchangeable for all intents and purposes. I prefer hypoxic ischemic just because that's more accurate. A true anoxic brain injury where there's absolute lack of oxygen is actually pretty rare. It occurs with carbon monoxide poisoning, but really not in other cases. If you've had near drowning, things like that, there's usually a little oxygen in there that's getting through. So this was something that Dr. Silo imparted on me. Hypoxic ischemic is more accurate, so we use that term. A lot of times, this is the result of someone who has a cardiac arrest, has CPR, they're resuscitated. They do okay from a cardiac standpoint, but then you find out they're having some cognitive issues, okay? And so what's happened? The brain didn't get enough blood flow for a period of time, so it didn't get enough oxygen to certain structures. And these patients tend to follow certain patterns of injury, okay? The areas of the brain that tend to be selectively affected by this are structures called the hippocampus, the basal ganglia, the occipital cortex, and Purkinje fibers of the cerebellum, right? And so what happens is these patients will often end up with a triad of symptoms. They have memory impairment, movement disorder, and in worst cases, vision impairment. Vision impairment is kind of spotty vision, blind spots in their field of vision. I like to call it Swiss cheese vision because it's not like they're blind all on one side. It's like they're missing spots. Often this is not picked up until later stages of the rehab when you're trying to get back to reading and things like that. And the therapist will say, hey, Doc, the person's really having a hard time reading. And I say, well, you're probably not able to see all the words on the page. So why does it selectively affect these areas? Well, these areas are very highly metabolic structures in the brain. These are areas of the brain using a lot of energy, right? Incidentally, a lot of these areas, particularly hippocampus, is an area where a lot of patients have lesions when they have seizure disorder. It's really metabolically active. What does the hippocampus do? It converts short-term memory to long-term memory, okay? So if you have injury there, you're gonna have memory impairment, which is probably the single most common impairment after hypoxic ischemic injury. So a lot of patients who have traumatic brain injury in the field, have resuscitation, may actually have an additional hypoxic injury that's accounting for some of the memory impairment and some of the symptoms that they're expressing, okay? The basal ganglia and the cerebellum are both involved in movement, right? Ataxia, apraxia, some of those things. Control and coordination of movement, not strength, but control and coordination. A lot of these patients will have rigidity. It's dystonic rigidity. A lot of well-meaning PM&R docs and neurologists will confuse this with spasticity, which is has a different mechanism. And so the treatment for it is different. Okay. So often for treatment of this hypertonicity, most of these patients will have, will be given things like baclofen for treating the tone, and all it's going to do is make them more sleepy because it's a different mechanism of action. Most of these patients are dopaminergically depleted. You guys probably have heard that dopamine is a neurotransmitter that's heavily involved in the basal ganglia, right? So a lot of these patients have dopamine depletion, and you need to replenish their dopamine, okay? All right. Secondary injury, once somebody has an injury, there's a lot of other things that happen. One of the processes, there's a lot of substances released into the intracellular matrix that can injure nerve cells. You have swelling, all sorts of things. So all the acute medical interventions are designed to prevent secondary injury, preserve brain. All right, so how do we do outcomes? How far can I go on? I know that's to the hour or in general, a total? Oh man, I'm talking too much, aren't I? All right, I wanted to get to, let's go through this predicting outcomes real quick, and then I'm gonna skip to the end because I think there's just some new research stuff that you guys wanna hear. So this is how we assess outcomes following brain injury. We have really these categories: premorbid factors, injury-related factors, and treatment-related factors. And all of these play into how severe somebody's injury is and how they're gonna recover. And then you wanna prevent the secondary complications, and that kind of gives you your overall outcome. So premorbid factors, first of all, whose brain was it? There are things like premorbid intelligence, socioeconomic status, education, all of those things have an impact on how well somebody's gonna do after brain injury. So this guy, when he falls off his bicycle, he probably is gonna do okay. Prior history of psychiatric problems is a big thing. I can do a whole talk on mood and mood dysfunction, mood disorders, and how it affects brain injury, genetics, and so forth. Other premorbid factors are kind of more general. Again, I mentioned age. Age is probably the single biggest prognostic indicator after brain injury. And sorry, folks, it's just a fact that once you reach, depending on who you read, age 55 to 65, you just don't recover as well. Older people just don't recover as well from the same brain injury. Socioeconomic status, location and availability of resources, type of insurance, all of these things really affect outcome. Injury-related factors, a lot of things that we've just talked about. How severe was the injury by GCS, duration of PTA, et cetera? What's the integrity of the rest of the brain? How much brain tissue is left behind? This is important from a neuroplasticity standpoint because how big the lesion is will relate to how much nerve tissue is left behind to recruit from for neuroplasticity and recovery of function. All of those factors are about severity of injury, location and type. Did the patient have other problems, seizures, hydrocephalus? Treatment-related factors. Did the EMTs get on the scene early enough to sedate them and intubate them so that they didn't have secondary hypoxic injury? Did they get to a level 1, 2 trauma center that had neurosurgery available? So all of these treatment-related factors. A lot of this has to do with control of some of those secondary injury factors, increased intracranial pressure and so forth. Did they get a craniectomy? This is really interesting. This was kind of controversial when I started in practice, that they were starting to do this, removing part of the skull to allow the brain to expand. And now it's become almost commonplace. And it really helps protect the brain. So you'll see a lot of patients with severe injury that have this. Want to give a shout out to our rehab colleagues. Extending quality of rehabilitation is one of the biggest things affecting your long-term prognosis. How well did the patient have access to, good quality rehab? So as life care planners, you want to make sure you get your clients to good quality rehab. It's going to affect their outcome. Okay, planning treatment. Everybody knows Wayne Gretzky, the great one. So he used to say, I'm a great hockey player because I don't skate where the puck is. I skate to where the puck is going to be. And so Dr. Silo used to talk about this as all. This is my old mentor, Dr. Silo, who really was a person who kind of established a lot of how we approach brain injury in the United States. People don't know his name enough, but great guy. Used to say, when in doubt, always return to the anatomy of the injury, because that's going to tell you how the patient's going to do. It's a roadmap for how the patient's going to progress. Every injury is different. So every person deserves and needs a specialized, individualized treatment approach. That's really, really important, that you can have 20 people with a GCS of 3, and all of them are going to, evolve differently. So the members of the treatment team, you see we've got a big group of people here, all hopefully working for the patient at the same time. Really, really important that you get alignment of expectations. There's a lot of misperception out there about brain injury, right? And this is why you really need to get everybody on the same page, kind of make sure you educate that family about what's going to happen, make sure they understand patient's going to get agitated, and educate them about what the long-term outcomes are going to be. And also, this is also important, get the team on the same page so that they're directing the rehab appropriately to the patient's deficits. Try to fix those alignments as quick as possible. So this is a comprehensive system of care. Back in the day, it used to be emergency, acute care hospital, inpatient rehab, and home. And you see things have gotten really, really complicated. I'm not going to go into all this right now because of time, but you can see the systems of rehab have gotten really, really complex. And one of the problems with this is every time that somebody changes from one setting to another, there's the opportunity for miscommunication, missing things. So a lot of times this is one of the big things, that when somebody transitions to a different setting of care, they miss problems. So, okay, I'm going to zoom through all this and just talk about imaging, gradient echo. So I mentioned difference between gradient echo. The MRI techniques are getting really sophisticated. On the left is, this is a great regular gradient echo, and this is susceptibility weighting. So you could see the lesions a lot better. So that's all improving. And just a real quick, advances in rehab care, some stuff that's coming down the pipe. A lot of things with supported treadmill training. This was a big thing at Shirley Ryan, that you have all these things to support the patient as they're walking. Functional E-stim was the big rage 10 years ago. Still using it, but not as hot a topic lately. Robotics is a big thing. Electroceuticals, a lot of new things coming down the pipe as far as electrical treatment. So 3 big techniques: repetitive transcranial magnet stimulation, direct TCDS, direct transcranial direct stimulation, deep brain stem. So I can answer some questions about all this. Stem cells people always answer about. There's actually been one good study that's actually shown efficacy. It's done by Sam Bio, and they've got another trial that's coming out in the next couple of years. They just got approved, so keep an eye out for that. This actually showed improvement in motor function on the Fugl-Meyer with patients with brain injury, injecting stem cells directly into the lesion. Model systems, and I mentioned this just is you can see some of the research that's being done currently in the model systems. And track TBI, the big thing that's coming out of track TBI, one of the big things that we've needed for years is a biomarker for brain injury, right? One of the things, particularly in litigation, is how do you prove somebody had a brain injury or not? You have a patient who maybe had a mild brain injury, CT scans, MRIs, all they look negative, patient's still having symptoms. How do you determine whether it's because of a brain injury or something else? If we had a serum biomarker to say, yeah, that person had a brain injury, that would help get rid of a lot of the conflict in the legal situation. It's coming. There are a lot of different candidates. The track TBI actually just came out with this paper. It's really new, using these two serum biomarkers, GFAP and UCHL1, that correlate with more severe brain injuries. So I think you're going to see a lot in the next few years about biomarkers and having maybe even a sideline concussion test, they prick a patient's finger and they can tell whether they had a brain injury or not, stuff like that, kind of cool things. There is a company that actually is trying to sell a device that's supposed to do that. I don't know a ton about it, but it probably is coming. So I'm going to stop there because I'm out of time. I could talk all day. So any questions? Yeah.
Line up behind me if you have questions.
On a low level TBI, what would be the range for the suspected improvement on executive functioning?
What would be the range?
Yeah.
Oh, see, I would go back to say it kind of depends on the individual. It depends on the anatomy of their injury.
I get that part.
So
too.
it's from none to all.
Oh, really?
Yeah.
Okay.
Kind of depends on networks that are involved. You have some patients that, and again, when you think about executive function, what area of the brain are you thinking about? You're primarily thinking about frontal lobe function, right? Okay. So we have plenty of people that have no injury to their frontal lobe at all, even though that's the most common pattern of injury, orbital frontal anterior temporal. You have some patients that have just an injury back here, cerebellar injury. So executive function is not a problem. So again,
What are the variables that would impact that the most then in terms of the rehab portion,
yeah, so the whole cognitive rehab aspects. Now these days I can actually, this has been a little interesting in my career. It used to be really common. This was back in the late 80s, early 90s. There were these programs that did cog rehab. And used to be cog rehab was the purview of neuropsychology, right? Well, what happened was there was a paper published through the VA that showed cog rehab has no benefit at all, which was, it was a paper that had some flaws, right? At the same time, though, there were these companies that were setting up these little computer stations, and they put patients for 8 hours a day at a computer doing computer games and call it cognitive rehab. So it depends on how you define cognitive rehab, right? And so rightfully so, I think insurance companies were getting frustrated that they were having to pay for 8 hours of cog rehab when that's really not what the patient was getting. And so, as a lot of times insurance companies do, they grab this paper and say, we're no longer providing cognitive rehab as a benefit. And so now the pendulum is kind of swinging back the other way because there's been a couple of big papers that have come out and demonstrate the efficacy of appropriate cog rehab. So this is usually done under the guise of speech therapy now. If you think about speech, language, and communication, there's a lot of cognition involved in that. So it's kind of a natural outgrowth of what the speech therapist did to be involved in cognition. Now, as a physician, I would also say, are you maximizing your neurocognitive potential with the right medication regimen? A lot of patients who have problems with executive function also have impaired cognitive processing speed and attention, and those are the more primary basic issues. So if you can treat those things, then the executive function gets better. But again, it all goes back to, it depends